Thank you very much, Jeremy. Thank you very much for inviting me here today. It's a real honor to be here. I think the sentiments that Dr. Santiago expressed are certainly ones that I experienced getting started as well. And as we're going to see, I think it's nearly universal when people are trying to start transitional care clinics. And so what I thought we could do today is go over different models of transitional care and look at what's worked, and then potential future directions as well. So as many of you know, the GU tract is one of the systems most commonly affected by congenital diseases. Neurological abnormalities of the spinal cord and brain often result in lower urinary tract dysfunction. Many patients with congenital diseases receive care from their pediatric specialists, as we all know, regardless of patient age. So at my institution, I work very closely, so I'm at Brigham and Women's Hospital in Boston, and I work very closely with the folks at Children's Hospital in Boston, which is actually connected by a bridge, so it makes the collaboration very easy. Their upper age limit for giving anesthesia is 35. And so that means that a lot of these patients, up until recently, were still getting their surgery and all their care at Children's, and so it's hard to break out of that model. As these patients do become older, many drop out of the healthcare system, resulting in costly emergency care as opposed to preventive care, and that's really the whole point of one of the points of this. So about 1,500 patients with spina bifida and other GU congenital anomalies are reaching adulthood every year. The 25-year survival of patients with spina bifida has increased dramatically over the last several decades, from 50% in the 1960s to currently around 82%. So a remarkable improvement. And as is alluded to earlier, a lot of that comes from improvements in management of renal function and improvements in infection as well. Patients with spina bifida and other spinal cord conditions have urological, neurological, and orthopedic conditions, all of which require long-term care. 94% of adults with spina bifida have some urological issues or complications, and Dr. Santiago pointed to a lot of the challenges that these patients face. Navigating a somewhat foreign adult medical system, social changes that they're facing, and dealing with independent living as well. So what are the needs? So appearance and body image are actually quite important to these patients. Continence, and as a separate issue, bladder function are also important. Sexual function, as they start to mature, this becomes an increasing concern for them. Fertility and pregnancy, and also bowel function. So these are all the things that we're dealing with. And having a team in place to handle all those needs becomes absolutely critical. So barriers to care. So a recent study of primary care physicians found a lack of adult subspecialists to care for patients with these congenital disorders. There just aren't that many people who have the interest or the training or the resources to take care of these patients with these complex issues. Their history is daunting. They come to your office with a big stack of medical notes, and it's up to you to kind of figure this out. You got 30 minutes if you're lucky, and if you're not lucky, 15 minutes. And it can be daunting for a lot of folks. Patients and families have often developed a close relationship with their pediatric caregivers, and they're often reluctant to give that up. Nevertheless, as these patients age, their needs change, and it's really critical that we provide the care that they need in an adult care setting, because in the end, that's what they're going to be needing for the rest of their lives. So the challenge is a lack of multidisciplinary care, lack of expertise and data regarding how we can do things better. Institutional barriers are also a major issue. So not just among different institutions, so from a pediatric hospital to an adult hospital, but even within institutions. Finding colleagues who can collaborate with you, a neurosurgeon, an orthopedic surgeon, a PMNR, a med-peds person who has an interest in this, that can often be difficult. Often getting the resources to have a point of care person to handle a lot of these issues is also challenging. Insurance coverage and reimbursement can also prove to be an issue as well. Just a little comment about the costs. The lack of an organized transition can be costly both financially and socially. The total lifetime costs of a patient with spina bifida were estimated to be over $600,000. About half of that was due to medical care and special education and equipment, but more than half of that was due to loss of work productivity and premature mortality. The caregivers of patients are also significantly affected by this as well. So the caregivers of patients with spina bifida worked an annual average of 7.5 to 11.3 hours less per week, translating to a lifetime cost of over $133,000 for them. So the costs affect not just the patient, but also the family and their caregivers. 43% of patients with spina bifida have been hospitalized within the past year, 86% within the last 10 years, and 14% require emergency room care. So the costs are enormous, both individually and across society. So this is a pie chart looking at our patient at Brigham and Women's and Boston Children's Hospital. So we have over 600 patients in our spina bifida clinic, and about a quarter, it's 165, it's actually higher now, have transitioned to the adult care facility. So what are the advantages? The advantages are increasing the likelihood of continuity of care, compliance, and also improving self-education and responsibility. So this is a bit redundant, but I think it's important just to emphasize that, I see our role as the transitional care urologist really kind of augmenting what's already there, and not to replace the pediatric urologist, but to serve as another counselor of sorts. Also working closely with the primary care physician and, of course, the patient and the family, in the end, are the people who end up making the decisions. So the fundamental elements for successful transition include incorporating preventive care, like we talked about, urinary tract infections, dealing with the metabolic issues that many of these patients face, bone demineralization, the chronic low-level acidosis people have if they've been augmented. Identifying these issues early and staving them off is critical. Educating patients appropriately about their conditions and what sorts of issues they're going to face down the road is important. Finding institutional support is, of course, important, and making sure that patients have family support, as well as encouraging a change in decision-making from a parent-focused approach to a patient-centered approach is critical. Okay, so now I thought we could look at some models of how people have transitioned and what's worked. And I think you'll see some common themes of what's been successful. This was a study, it's actually an opinion piece by Dan Wood. He's a urologist in the UK, and his focus is transitional care. And he surveyed the landscape in the UK and kind of came up with some things that he thought were common to pediatric care facilities and adult care facilities. The things that he identified, when it comes to patient management in the adult care facility, you have a smaller team, you have subspecialty expertise that may involve multiple different surgeons and different teams, and that's different from the pediatric care setting where it's often one large team led by a single surgeon. The care approach is a little different. This is often patient-focused in the adult facility as opposed to parent-focused in the pediatric facility for obvious reasons. The clinic appointments can actually be a major issue. So they're shorter in the adult facility as opposed to kind of longer, more detailed discussions that can occur in the pediatric facility. And follow-up can be spotty depending on the types of resources you have available. So this led him to conclude that key attributes of a successful transitional urology unit include the following. So there's no real fixed model for transitioning. There's no one model fits all for every facility, but a lot of it's going to depend on the resources that you have available. But what makes a successful model is having a multidisciplinary team. Preparing the patients early in the process is key, and also identifying that these patients need lifelong care and then getting them set up with the appropriate specialists in the adult care facility. This was another study from the UK, and they looked at the literature and identified 10 studies. This was a systematic review of all sorts of illnesses, so not just urological illnesses. This included cerebral palsy, it included cystic fibrosis, and they identified 10 studies that looked at transition between the pediatric facilities to the adult healthcare model. They found that of those 10, 6 showed a significant improvement. And they identified 3 main areas where these successful models really proved their value. So one was focus on the patient. The second was identifying the proper staff. And the third was dealing with the delivery of the care. And we'll go through those now. So when it comes to the patient, attributes of successful transition programs included disease-specific education early on in the counseling of these patients while they're still adolescents. So specifically educating them about spina bifida and the sorts of issues that they're going to face down the road. Skills training was something else that they found to be important as well, and this included both one-on-one training but also even virtual training. So on the internet was actually found to be equally effective. And when it came to staff, they found that having one specific coordinator, one point person, became absolutely critical. Having a joint pediatric adult clinic was another aspect of successful transitions, and so that's something that they advocated. And when it came to delivery, one of the issues that they identified was in unsuccessful models was that patients often had no one to call, or they were confused about whom to call. So having after-hours phone support made for a successful transitional clinic. And these patients often required enhanced follow-up, so preemptive calls, similar to what many of us do with our bladder cancer patients. They get calls from nursing staff, on a weekly basis. They come in for fluid boluses periodically, and these patients require the same level of close hands-on care. And so that had a significant impact on improved delivery for these systems. This was a study from Oklahoma, from Dom Frimberger's group, and they looked at their own clinic. And when they looked back, they felt that around 100 patients had been inappropriately transitioned. And when they really examined it, the response was to establish the REACH clinic. And we'll go through what the REACH clinic was. Prior to changing this, the paradigm that they had, the patients were being transitioned and they followed up with the adult urologist. The transition did not include much in the way of education, but we'll see how they, or in terms of assessment of readiness. And so we'll see how the REACH clinic changed all that. One of the major changes they made was having a structured, formalized staging framework. So identifying patients and putting them into different categories of readiness. Are they ready to be transitioned? Are they already down the path of being transitioned? Have they already transitioned? Having the structured, formalized framework allowed them to more appropriately get people down the pathway. They have a specific social worker who helped guide all these patients. So as identified in the previous study, one of the successful aspects of their model was having one point person, and this was a social worker. They have a monthly clinic where they see all their patients together, and their clinic includes an adult urologist, a pediatric urologist, 2 NPs, and a social worker. Generally, in their clinic, patients less than 14 years old, younger than 14 years old, are seen by the pediatric urologist, and at 14 years old is when the transition process begins. It's not universal, but those who are deemed ready to be transitioned start to undergo the process at that point. They have a T0 to T4 staging framework, and we'll see how people are categorized by this system. So T0 patients are patients who are not yet ready to transition, but potentially deemed eligible. These are typically early adolescents, 12 to 14-year-olds, patients who have the executive function and have the desire, or at least potential for the desire to transition. T1 patients are patients who are in their first stage of active transition, and in this stage, patients undergo frequent discussions about what the transition process will include, what life will be like in the adult care model, and they undergo frequent readiness assessment through a variety of questionnaires. This typically occurs between 12 and 15 years old. Patients in the T2 group undergo continued assessment, but here the shift is now to identifying barriers to their being able to function in the adult care facility. They're still seen by the pediatrics team, but as they advance to the next stage, the T3 stage, they're now seeing the adult team, but at the pediatric clinic. This is actually something similar to what we do, and I know Dr. Santiago does as well, and probably many of us do. We'll go to the pediatric facility, see patients with the pediatric team there, and then that'll help smooth the transition. And there are other things that we do that we'll discuss afterwards. But that's a common paradigm that you'll see in these successful programs. T4 patients often see are now advanced to the stage where they see the adult team in the adult clinic, and the pediatric team has minimal interaction with these patients at that point. They use the validated questionnaires that's available on gottransition.org. For those of you who are not familiar with this, this actually is a really useful website with a lot of resources. They have a readiness assessment that's available. In addition, they gave them many other questionnaires, including the ICIQ, SHIM, and SF8, and sort of track their progress over time. So roughly half of their patients are in the T0 stage. So you can kind of think of it as the pre-contemplative state, right? So they're deemed eligible, but not started on the process. And about half are in the T4 stage, so having transitioned already. And then a smattering of patients are kind of in transit. This is a study from Indiana. Here again, they kind of look back at their own experience and try to identify how successful they were. They have a multidisciplinary clinic involving a pediatric and adult urologist, and they looked at 77 patients over a 6-year period. They identified a successful transition as one in which patients followed up within 24 months, which is actually a pretty generous time period. And they looked at the outcomes of patients who were put into 3 different groups. People who underwent a successful transition, so followed up within 24 months. People who underwent a late transition, who eventually followed up, but it just happened to be after 24 months. And people who did not transition at all. And they sort of compared the outcomes of these 3 groups. 40% of their patients underwent a successful transition, 9% underwent a late transition, and 51% underwent no transition at all. So they compared these groups, and the one difference that they found, the one statistically significant difference that they found, was in terms of emergency room visits. So patients who had no follow-up, no transition, ended up having a higher percentage, a higher number of emergency room visits compared to those who transitioned, or even those who transitioned late. And so they came away thinking that this was the major benefit from this. Although this is a small study, and potentially with bigger numbers of patients, they might see changes in some of these, improvements in some of these other parameters as well. So just a brief overview of what's out there. So in summary, I think it's important to emphasize that there's no one successful transitional model that fits all. A lot of it's going to depend on what resources you have available. I know at our facility, we are fortunate to have an incredible care coordinator on the pediatric end, and the hospital is now putting resources toward a similar role in the adult facility as well. I think what makes for a successful transition is being able to slowly introduce patients to the idea of the adult care model, and even giving them tours of your facility to try to get them familiar with the new landscape and how things work. I think being able to counsel patients about some of the frustrations that they're going to face is also critical. As patients are transitioning, I sort of counsel them in the same way that I do for sort of major abdominal surgery. And I tell them, look, this is going to be a frustrating process, and it's not going to be an easy one, but it's going to be worthwhile. And in the end, you know, this will be the best thing that can help you to get to where you want to be. And I think if you set the expectations early that it's going to be different than the pediatric care model, I think that helps to calibrate everybody, including the family. It's important to work in a multidisciplinary fashion, so not just with your pediatric colleagues, but also with your orthopedic, neurosurgical colleagues, working with physical medicine, and also a med peds person as well. And the importance of having a dedicated social worker and nursing staff really cannot be overstated. It's important to note that the high costs of failure to transition properly are really a societal issue, and ones that are also borne by the patient and their family as well. Some of the unanswered questions, identifying the optimal transition model. We really don't have the appropriate assessment tools to determine when people are ready. We do have kind of broad general tools that help us to identify patients with many congenital issues to identify when they're ready. But this is broadly used, and we don't have one that's specific to urological diseases. And so identifying patients can be challenging. Assessing when they're having undergone transition can also be equally challenging. And so having the appropriate questionnaires and the appropriate assessment tools is still a work in progress. Identifying their quality of life, similarly, these are unanswered questions that I think we're, as a group, continuing to work on. I think future directions include establishing better guidelines, establishing smoother transitions within and among hospitals, and of course funding and research, both translational work in terms of long-term clinical outcomes as well. Thank you very much.